Please join me in welcoming Dr. Bob Snyder.
Thank you. We have a lot to cover tonight, and I'm going to go through things fairly quickly. We'll have a chance later on to ask all the questions that you'd like to have answered. I picked a topic that's pretty broad. How can I make my knee stop hurting? Lifelong options. Certainly, we're going to talk tonight about surgery and surgical options, but one of the take-home messages is certainly that surgery is not necessarily the final answer for anybody's knee hurting. You certainly have a lot of other non-operative options before you get to that point. Basically, the knee joint is made up out of bones, ligaments, cartilage that covers the bone, and a meniscus. Everybody is familiar with the femur bone. It's connected to the tibia bone. The patella makes up the third bone of the knee. What supports the knee are the ligaments on the outside of the knee, the lateral collateral, medial collateral, and the two ligaments that run through the knee, which is the anterior and posterior cruciate ligaments. The articular cartilage which I always say is analogous to the white glistening cartilage on the end of a chicken bone, is the articular cartilage that covers the femur and also covers the tibia. And then we have kind of a built-in suspension system, which is the meniscus, which is a separate type of cartilage that basically acts as a shock absorber, that's in the knee. The natural history of a knee is certainly, as we grow from infants to when we mature, the bones are growing, ligaments are growing, cartilage is basically growing. We all can repair to a certain extent damage to a knee. If a 5-year-old were to damage the cartilage in his knee from the fall, chances are by the time he was fully grown, that cartilage would have been repaired. Unfortunately, as we age, we lose that ability to heal our cartilage or to repair our cartilage, and that's where we face the dilemma of what happens when we lose that cartilage and develop arthritis. The other factor that comes into a knee is how the forces are distributed across the knee. As we talked about and showed, there are certain forces that go through the inside of the knee, forces that go through the kneecap area, and forces that go through the outside of the knee. The majority of the weight, when every step we take, goes through the inside of our knee. Up to 65% of each step is going through the inside of the knee, which is typically why when people end up needing surgery for their knee, they have a tear on the meniscus on the medial side, or they develop, as they get older and arthritic, a bow-legged appearance because basically the inside of the knee is wearing out. We also, distribute our weight across the knee. The more we weigh, the more force goes across the knee. That goes without saying. Activities also contribute to the forces across the knee. When somebody goes up and down stairs, oftentimes up to 6 times their body weight is going through portions of their knee. So if you imagine that, for somebody who weighs 200 pounds, multiplied by 6 is 1,200 pounds of force is going through certain parts of the knee, and you can certainly see why, we stress weight reduction and other treatments for arthritic knees. So what happens when we take the natural history that we've talked about of a knee that loses its ability to repair cartilage, combined with a lifetime of different forces that go across the knee, and we find that normal articular cartilage that's in the knee starts wearing away. It becomes very friable. It becomes very thin. All of that is known then as osteoarthritis. Arthritis, when it starts out in just a very small area, and this is a picture inside of a knee of just a normal cartilage here and a big chunk of cartilage missing there, is arthritis. It's just that we don't see that arthritis on an x-ray yet. Of course, when you get to the most extreme case on the inside of a knee, where there's nothing but bare bone that covers the femur and bare bone on the tibia, we're going to see that, you know, on an x-ray. So basically, you know, we're all born with a healthy knee with normal cartilage. As we get older, our cartilage loses its ability to repair itself and heal itself. That leads to arthritis. The other thing that leads to arthritis is just our genetics. I mean, some of us you know, come from families where, you know, everybody seems to develop severe arthritis by the time they're age 50, and other patients are blessed or come from families that may not exhibit a lot of arthritis in their joints ever. That's kind of the reason why two people can work side by side for 50 years, do the same job, never have an injury. You know, one person has an x-ray of their knee, they're full of arthritis. The person who worked next to them did the same job they did for 50 years, comes in, has no arthritis in their knee. On top of that, we add injury, whether it's an old high school football injury, a college injury, an injury with a fall, a motor vehicle accident, that changes the dynamics. We can have somebody who comes into our office who's 60 years old, has no arthritis in one knee, has their other knee full of arthritis because when they were 17 years old playing high school football, you know, they sustained a serious injury to their knee that resulted in instability to their knee, and subsequently over those years they developed a lot of arthritis. So what does arthritis look like on an x-ray? Basically, on an x-ray, instead of having a normal, you know, space, and this happens to be arthritis on the inside of a knee, arthritis on an x-ray, you know, shows that there is no space there, and we call that basically, you know, bone-on-bone arthritis. How do we deal, you know, with arthritis? I mean, arthritis has been around for thousands of years. You know, we can deal with it with medical treatment, knee injections, you know, surgical options, and lastly, with joint replacement. Medical management involves health and behavior modification. You know, if we lose weight, we'll put less force across the knee. You know, our arthritis won't affect us as badly. If we do a lot of running and we've developed arthritis in our knee, we elect to maybe exercise with less forces across the knee, perhaps by riding a stationary bike, or doing aquatherapy or swimming in a pool to eliminate the force across the knee. We hear a lot these days about glucosamine and chondroitin. Glucosamine is one of the substances that actually makes up cartilage, and it's been shown that when we take glucosamine orally, it will actually end up into the cartilage. Now, it would make intuitive sense, therefore, if we took glucosamine, that it would in fact help our cartilage. The dilemma is that we all take in glucosamine in a normal, healthy diet. And glucosamine would be one of those substances that we don't really store, to use for a rainy day if we develop arthritis. So there are some studies that show that glucosamine can help with arthritis. There are some studies that show that it really does not do that much more than just taking some Aleve or Tylenol to help your symptoms. Does it work? It probably works. It works. Some patients swear by it. Others take it and really see no effect of it. What I tell patients is that if they've been taking it and they feel that it's working, then certainly by all means continue it. If you feel like it's not working, then it's probably not worth the amount of money that some of those medications cost to stay on it. Medical management involves medications. Basic Tylenol is the mainstay for arthritis. Main advantage is that it doesn't contain anything that really upsets the stomach. Most people can take Tylenol and not really exhibit any side effects. So Tylenol is a basis for medical management. The NSAIDs, or non-steroidal anti-inflammatory medications, are things that we're all familiar with: Aleve and Advil, and they go on through the fancier medications and ultimately end up in Celebrex, Mobic, and newer medicines that come out all the time. Bottom line with the NSAIDs is that there's never been shown that one NSAID works any better than another one. What has been shown and what we see every day is that what works for one patient might not work as well for another patient who may benefit from a totally different medication. So most of the time when we prescribe NSAIDs, we start out with the over-the-counters, Advil, Aleve, and a lot of patients find that that's very effective. And if that's not effective or they can't tolerate it because of certain side effects, then we'll certainly start going to the newer medicines. One of the advantages that the newer medicines have is that you don't have to take them as often. Medicines like Celebrex, Mobic are just once-a-day medicines. We find that if you can take a medicine just once a day, there's a higher chance that you'll stay on that medicines. Most medicines that you have to take 3 or 4 times a day, the average person may not take them as prescribed, may only take them once or twice a day, and subsequently, would say that the medication is not working. Lastly, we include braces and orthotics. An orthotic device can be a simple little wedge that fits into your shoe that basically allows you to either turn your foot in one way or the other to decrease the forces across your knee. Braces can run all the way from simple slide-on braces that look like sleeves made out of cotton or rubber to braces like the one picture on the right, which is basically an unloading brace that an athlete would wear in an attempt to try to decrease the pressure on the side that the arthritis is in the knee. The problem with braces is that unfortunately they have a tendency not to stay in place, and they become very expensive. I always kid that the reason they have timeouts in football is so everybody can reach down and adjust their brace for the next play. We talk about injections in the knee for arthritis. There are 2 types of injections. Corticosteroids refer to the common steroid injection in a knee, which everybody associates with bad side effects because they read about the steroids in the paper and steroids that athletes take. Steroids have been around a long time. Your body naturally produces steroids, and properly administered, a small amount of steroid that's placed into a knee on an every 3-month basis will over time not produce any bad effects for that knee. Now, if we were to take a steroid injection and put it in your knee every week for a month or so, then there is a possibility that a steroid can soften cartilage and actually, lead to more arthritis in a knee. But we treat a number of patients that have arthritis in the knee, and they find that if they have a steroid injection in their knee on an every 3-month basis, they're able to perform all their normal activities. They don't have a lot of pain, they don't have a lot of swelling, and for them, that becomes their treatment. And until it changes that's not working anymore, then that's an effective treatment. Viscosupplementation refers to like jelly type solutions that we inject into the knees. They're usually indicated for 6 months. They can't be repeated again until at least 6 months. Some of the brands that are out there come as a single injection. Others come as a series of injections, either 3 injections or 5 injections administered a week apart. Some of the names you'll hear are things like Suparts, or Synvisc, or Orthovisc, or Euflexa. They are all talking about viscous supplementation. What they're injecting into your knee is actually high hyaluronic acid. It's a thick type of solution. Most of it is processed from rooster combs. A rooster comb is made up of basically cartilage, and they can degrade that and basically, modify it, sterilize it, and inject it into a knee. Bottom line is that these injections, do not grow cartilage. They do not heal cartilage. They are basically a lubricant in your knee, and that's why the WD-40 is up there, because it basically would act the same way as if you could inject WD-40 in your knee. The difference being that these are formulated to last for a while and not break down quickly, so they stay there. So basically, treatment of knee arthritis, short of surgery, involves basic common sense things that we've all grown up with. Medications, whether they're over the counter, whether they're prescription, basically rest, modifying our activities, ice after exercise, supplements such as glucosamine, the right type of exercise, and weight reduction. Well, those things worked good in probably, the year 1712. What's different in 2012? Well, I think generally are more active with age than people were in the 1700s or 1800s or early 1900s. Years ago, when most people were growing up, our parents didn't play sports after high school. They stopped exercising after high school. Nowadays, people play sports in high school, college. After college, there's recreational leagues. People play lifetime sports now up into their, up into their 70s or 80s. If you go to the Boston Marathon, you'll find that there's an 80-year age group you know, of people who are still running marathons. So certainly, you know, we're more active than we were. We play sports longer. Look about us. We all weigh a lot more than people weighed when we look at pictures from the 1920s, when everybody looked like they were cookie cutter, you know, size 32 waists and all about the same height. We are a lot heavier than we are now. Our joints have not been able to keep up with some of that extra weight. That's what's different today. The other thing that's basically different about today is that knee replacements have come along. Up until about 1970, you know, knee replacements were still in their infancy. They were being put in some patients, but not nearly to the rate that they are today. Basically, nowadays about 1 million patients a year are getting knee replacements. If you looked at basically 5 years ago, the number was about 500,000. So in the last 5 years, you know, the numbers have doubled. When you look at projected charts over the next 10 or 15 years, the numbers just keep going straight up like that. And looking at the number of people who will probably be looking at knee replacements. The other thing that's really different in 2012 was that, you know, we've learned a lot more about metals. We've learned a lot more about plastics. We've learned a lot more about manufacturing techniques, and we've been doing active research on knee replacements now over the last 50 years. So in 2012, we certainly still have the operative or non-operative, you know, treatments that have existed, you know, for years. Medications, injections, rest exercise, weight reduction. But nowadays we have, you know, operative solutions, and the operative solutions include arthroscopic surgery, osteotomies, and joint replacement. In an arthroscopic procedure, the surgeon can insert a small scope and instruments in a knee and basically, you know, take a knee like it's pictured here and trim away, you know, torn meniscus. The cartilage that's worn here, you really can't do anything that's going to allow that to heal itself because cartilage doesn't heal. But oftentimes you can take out the loose pieces. We call that debridement. And that will, you know, provide a certain period of pain relief and allow the patient to return to increased activities. Osteotomies are not done very often nowadays. You know, osteotomies have historically been indicated for somebody who perhaps was in their 20s or 30s, and because of an injury. And years ago, it was usually a farm injury or an industrial accident that left somebody with such severe arthritis on one side of their knee that by going in there and cutting the knee and removing a section of bone, you could shift the weight basically from the bad side of the knee to the good side of the knee. And that allowed the patient to continue to work, basically. And eventually, years later, when the other side, the good side of the knee, then wore out, you know, then of course, you know, they usually required a knee replacement. You know, the last topic on surgeries is the knee replacement. Again, as we talked about the knee, we showed that there were 3 compartments to the knee, you know, medial side, lateral side, and the area around the kneecap. One option is certainly to replace just one side of the knee, either the inside or the outside. Those are called uni-compartmental replacements. If somebody has arthritis on the inside of their knee and their kneecap, then they can become a candidate for a bicompartmental. A total knee replacement, by definition, replaces the entire knee joint, all three areas of the knee. We talk about resurfacing. The primary difference between a replacement and resurfacing is that resurfacing by its name implies that we're just not going to remove very much bone or hardly any bone at all, and basically just replace the end of the bone where the cartilage was with metal that will approximate the same thickness that the cartilage that was originally worn off of the knee. A total knee replacement, has been the gold standard, for many years. I mean, partial replacements have been out there, but the gold standard for many years was a knee replacement. If somebody went in to see a surgeon that just had arthritis on one side of their knee, they got a knee replacement. If they went in to see a surgeon that had arthritis in just two areas of the knee, they got a knee replacement. Knee replacements have benefited because we've developed better metals for the knee, better plastics for the knee, and subsequently, we've been able to develop knee replacements that have been able to, stand up now to, 15 to 20 years, in the right type of patients. Still, total knee replacement is a big operation, and it certainly carries significant risks. And more importantly, it does require a long recovery or rehabilitation process. This picture is just to show arthritis in a drawing, bone-to-bone contact like we've talked about before. Currently, knee replacements involve, just like this model, it's basically it's a plastic bearing that's placed between one piece that fits on the end of the femur bone and another piece that fits on the end of the tibia bone. We can attach the metal piece to the femur bone or to the tibia bone by cementing it, or in some patients we do not cement it, in which case the implant would be gritty and rough, and we basically just press fit it onto the end of the bone, and the patient's own bone kind of grows into the pores, and that helps lock it into place. One of the advantages, obviously, of doing that is that it decreases, the risk that there's going to be a problem with the cement that's used to cement these things. The problem is that, as we get older, our bones get a little thinner. We develop osteoporosis, and if we have, any thinning to our bone, there's a likelihood that when we try to press fit something into the bone, that it may not heal in there, and subsequently it's going to become loose, and if it doesn't heal in there solidly, it's going to cause pain and subsequent swelling. As you can see, most knee replacements, and up here I've included a few different knee replacements from different manufacturers. They are all basically come pre-made. They come from size 1 to size 6. They come in a left and a right, almost like you're buying a pair of shoes. The plastic that fits between the femur and the tibia comes in different thicknesses. Oftentimes, if there's a bigger gap you have to fill up, you have to use a thicker piece of plastic. And so there's all kinds of variations in how you can build a knee. We all know that, no two knees are alike. There's gender differences. Women's knees are usually a little thinner across the side of, the width of the knee. And some implants, if they're not produced correctly, may have a tendency to hang over the edges of the bone. So some of the implant manufacturers actually have knees that are designed to fit women, knees that are designed to fit men. As you can see, if we hold up this knee replacement here, before all the pieces have fit on there, we've cut away quite a bit of the bone, and we make up for those thicknesses or the cutaway bone with these preformed pieces that then fit on to the end of the bone. Always a question about longevity. And how long these things last. You'll see advertisements in some papers that some knee replacements have been tested and may possibly last 30 years. Really what they've done is they've taken a model in a lab and cycled it through 30 million revolutions, which would be about how many steps an average person would take in 30 years, and then they've measured how much it's worn. Of course, there's no computer model that simulates what the actual knee does on a day-to-day basis. I mean, our knee does not work like a true hinge, so there's really no model or machine that they can put it in that would truly simulate what happens to a normal knee. When knees do wear out or there's problems, then knees need to be revised. So if we cut away a large section of the bone to do a primary knee, and this is a picture of a off-the-shelf, cemented knee replacement. We can see where we've had to cut away a lot of the bone here, a lot of the bone here to make those pieces fit. And basically, this is a schematic showing that we use a combination of different jigs and saws and cut away big sections of the bone until ultimately we can fit the pieces on. These are some pictures of a knee replacement, and basically you go through different steps with different size jigs and make different size saw cuts until ultimately one of the sizes that are already been prepared can fit onto the knee. Picture on the left is a standard knee replacement. If you were to have problems with something like that and had to take it out, whether it was because it was infected or loose, then sometimes you'd have to replace it with what you see on the right. This is called a revision knee replacement. A revision knee replacement has to make up for all the additional bone that's lost in trying to take these pieces out. When you take the pieces of a knee replacement out, oftentimes they're stuck to bone, and when everything is taken out, you're left with a huge gap, and you make up that space with basically larger components that have stems that go up into the bone, so that it helps anchor them a little bit more, because again, you've lost a lot of that original bone that would have been used to anchor them. What are some of the factors that influence how long a knee is going to last? We've talked about the weight. We've talked about wear and tear. Every knee works differently over a period of years. Certainly, some patients that have a knee replaced may have trauma to their knee. They may have additional injuries to the knee that can affect how long the knee can last. The other things that can affect the knee are the surgical factors. And, surgical factors meaning that, was there a problem when the cement was mixed that made the cement not hold correctly? Was there a problem in putting a piece of plastic that perhaps was too small that allowed the knee to have too much instability that caused the knee to wear out? The most important factor, though, that affects longevity to the knee is how accurately the knee is put in there. And by that we mean, when the knee is in there, did it correct all the angles? Did it restore the damaged knee to have the same alignment that a normal knee would have? You've seen how most of these cuts are made by hand using a cutting block. And if anybody has worked with lumber and trying to take a saw and cut a board at an exact 90-degree angle, you'll know that it might appear to be 90 degrees, but if we put a square on it, it might vary from 87 degrees to 93 degrees. And then if you turned it the other way, it might even be off more than 10 or 15 degrees. We've done elaborate studies that show, in older patients, you can accept some malalignment, and for the most part, patients will still do well. But when we start swinging the pendulum to doing knee replacements in younger patients, if the alignment's off, then the patient feels that, and their most common complaint, if you put a knee replacement in a younger patient, is that my knee just doesn't feel right. It's still, I may not have the pain that I had before, but my knee just doesn't feel right. So how do we improve the alignment in the knee? Robotic surgery, is utilized now, by a lot of the urologists, some of the general surgeons. We can sit in a booth with remote controls and operate laparoscopically in the abdomen. There's really not a good robotic surgery that's been applied to the knee. There's been some devices that have attempted to hold the knee like a vise and have machines that will come up and try to cut the bone more accurately. We've gone through computer navigation, which is basically bringing a huge computer into the operating room that has probes on it, and some of the probes actually go onto the patient and onto the knee, and the other probes fit the instruments themselves. And so you can hold a saw up to the knee, look on a computer screen, and it'll say, if you cut it right there, it's going to be 89 degrees. If you turn your wrist a little bit, you can get it exactly at 90 degrees. So, it's all an attempt so that we can make those cuts as accurately as we can. One of the problems with computer navigation is, though it's big machines, you have to wheel them into the operating room. If some of the sensors are off, then some of the cuts will be off. It adds about, in some cases, an extra half hour to 45 minutes to a case. And so the patient's under anesthesia for a longer period of time. There's more potential for intraoperative problems. And subsequently, it can result in a longer hospitalization. So what would be the ideal knee replacement? If we could get everybody together and come up with what we'd consider the normal or the ideal, it would have a certain number of characteristics. Number one, we'd want to preserve bone. We don't want to cut away a lot of bone. We want to keep as much bone as we can. We want to cut away just the arthritic areas of the bone, And part of that reason is so that if we ever have to do something else down the road, we still have options. Obviously, we'd want to replace the worn areas of the knee. More importantly, we want to have a knee replacement that had the proper alignment in the knee. And then our ideal goals would be a short hospitalization, less pain, fast recovery. You can't argue with those. We've talked about a conventional total knee replacement, and if we're replacing the entire knee, number one, we cut away large areas of the bone. If somebody has only arthritis in one area of their knee and the other two areas of the knee are normal, when they get a total knee replacement, they're basically cutting away those normal areas of the knee and replacing them, replacing normal areas. Most times a total knee replacement sacrifice a lot of the ligaments that are inside the knee, the anterior cruciate ligament and the posterior cruciate ligament. And one of the other disadvantages of a conventional total knee replacement, because we've cut away large areas of the bone, if somebody were to have something else done down the road, either because of a new injury, loosening, infection, other reasons, well, it affords them limited options because there's less to work with at that point. Partial knee replacements get around some of those problems. Partial knee replacement will only replace that area of the knee that has the arthritis. One of the statistics that I've read is that about 20 to 40% of all knee replacements are performed on people who could have probably been treated with a partial replacement. And that's primarily because, in some areas of our country, partial knee replacements really have not taken hold. Basically, all surgeons, if you have arthritis in your knee and you're going to get a replacement, you're going to get a total knee replacement. I think a lot of that comes from just the ways that surgeons were trained. If they didn't go through training programs where they got a lot of exposure to other techniques, they're basically gonna do in what they were trained. Patient satisfaction seems to show that partial replacements or unicondylar replacements are preferred by patients because the partial replacements preserve the ligaments. In other words, with a partial replacement, my knee is going to feel more like a normal knee because I still have my normal ligaments in my knee. Partial replacements is going to preserve cartilage, preserve bone, less invasive, less blood loss, smaller incision, faster recovery. What's the disadvantages of a partial replacement? Well, the main one has been in some studies that partial replacements do not seem to last as long as normal replacements. Some of that, again, goes to the earlier models of partial replacements required a lot of instrumentation. A lot of people didn't do a high enough volume to really become very good at them, and some of the design features, were poor and they didn't last. So there were some studies on partial replacements that showed that the partials lasted as long as knee replacements, and other studies that showed that maybe they only lasted half as long. And then the question is, what happens if you get a partial replacement on just the inside of your knee, and then you continue over years to maybe develop arthritis in other areas of your knee, and what options do you have available then? Certainly, again, the advantages of the partial: it preserved the ligament, faster recovery, less bone. And then what has come along recently is custom knees, or custom partial knee. And the last thing I mentioned is the Conformis system, which is a system that I utilize, and basically it's the only knee replacement system out there that's truly custom made for each individual patient. So it's only going to replace, it's going to be made for each patient, off of a model of that patient's knee, and it's going to fit perfectly and accurately because all of the alignment has been taken care of in the manufacturing side and doing the pre-operative studies that are required. Conformis knees basically can do a partial replacement. Conformis now has a total knee system. Conformis knees are sometimes called total knees, and they're sometimes called total knee resurfacing. And again, resurfacing implies that we have not removed very much bone. We've basically removed only the worn cartilage in your knee, and basically the metal pieces that now cover the bone are basically designed to replace the normal cartilage that used to be in those places and are about as thick as the normal cartilage that was in a knee. Basically, the way these things are manufactured is that a CAT scan is done of the knee, and then the CAT scan is reconstructed mathematically to create a computer model of the knee. They use a technology that basically enables them to look at the diseased knee, take a CT scan of the knee, can create a computer model then of the knee, and map out the areas that need to be replaced, and basically design an implant that's individualized for that patient. To go along with it, they make disposable instruments that are used during the surgery to place on the knee so that some accurate cuts can be made, and you're in the right position. There are a few very small cuts that are made, a few drill holes that are placed, and then the actual piece is going to fit on almost like the crown on a tooth. And again, because it was computer manufactured off of a CAT scan, and when they do the CAT scan, they include a little bit of your hip, a little bit of your knee, a little bit of the ankle, so that they can recreate the normal angle. So if somebody has a very angled out knee after they have this operation, their knee is going to have the normal angle that their normal knee had. It's going to try to restore their knee back to the way it was, before it had arthritis. Again, this just goes back over the other slide. Starts out with a CAT scan. Basically, it converts the data to actually form an individual implant. The implant is going to fit exactly on the knee, fit right on the bone that's on the knee. And to do that, they have disposable plastic instruments that basically come to help guide the surgeon to make a few drill holes and things that need to be made that help hold this thing on. So the advantages of a personalized partial knee are the same advantages of partial knee, plus every implant is made for you, so the fit is personalized or perfect. The tools for the surgery are also designed, to fit your knee only, to make, perfect, cuts. And basically, the cost is similar. primarily because these implants are made on a one-for-one basis. If you go to, Mary Immaculate or to Riverside, they all have a room in the basement where they basically have to keep an inventory of all the pre-made knees, and basically like a shoe store, they have to have every size from size 1 to 6, lefts and rights. They have to have all the plastic spacers that fit in. When knees are custom made, they just make them once. They send the pieces to the surgeon. They include all the instruments that the surgeon needs. Afterwards, there's no need to wash those instruments, re-sterilize them, repackage them, put them back up on shelves. It's basically, they're designed to be used once and then thrown away. Again, this is an example on the left of a knee that has just arthritis on the inside, one compartment. That's what the X-ray would look like. This is what the implant, that's what a Uni-compartmental implant would look like. Just would replace one side of the knee. This is a model actually in the knee. You can see in this case it's just replacing one side of the knee. The pieces that get sent are going to exactly match the bone. If somebody has arthritis in one side of the knee and up under the kneecap, well then they become a candidate for a bicompartmental. And again, this implant would be designed to replace either the inside or the outside of the knee, plus the kneecap area. And again, like we talked about, if somebody has arthritis in all three areas of the knee, then the Conformis does also make a total knee replacement. So basically, the process works by doing a CAT scan of a knee, making a model of the knee, creating special implants that are plastic, that are used to fit on the bone to make a few of the drill holes and a few of the cuts. And then packaging everything up, everything, the actual implants are here, the actual plastic pieces are included. All of the drills, all of the guides, everything is included in one pre-sterilized kit delivered to the hospital, and basically put in then with standard instruments that every hospital has. It's all patient-specific design for the implants and for the jigs. Again, research has shown that if you take a pre-made knee replacement and put it in a knee, it's going to either overhang or underhang about 3 millimeters in some areas, and that basically the standard implants do not match every size of every knee that's out there. The Conformis implants, since they're custom made, are going to basically cover 98% of the tibia, compared to basically 57 to 67% coverage when you use a standard implant. So it's kind of like building a foundation, for a house to rest on. If the house is larger than the foundation, it's going to overhang. It's not going to get the right support. If the house is too small and doesn't reach all of the foundation, then the house is going to sag in certain areas. It's not going to get the right support. Subsequently, it's going to wear out quickly and fail. When the Conformis knees are sent to the surgeon also receives an outline of how the implant is supposed to look in the knee, where the arthritis is in the knee on the edges, some of the bone spurs that'll have to be removed to ensure a perfect fit. The surgical technique is basically, removing all of the cartilage that's left in that area of the knee, in this case, just one side, balancing the knee, making a few basic cuts, preparing the bone surfaces, cementing the implants in. This is an animated model of the surgery. Again, just one side of the knee. The surgeon draws a line, where the cartilage is going to meet the implant. All that remaining cartilage is removed with a curette, and basically down to bare bone, and that's what they're doing here. The knee is balanced with a jig that fits in there that comes in different sizes. Off of the jig, a cutting block fits, which is basically determines correct alignment. A few basic, drill holes are placed to hold it into place. We take a saw then and make a cut, right along the guide there, and then another blade comes in and we make a smaller cut, and the piece that's removed, we'll take a small piece out. The actual implant is going to fit exactly in there. We put the femoral guide back on, determine, re-verify the correct position, put some additional drill holes, in there, and then cut off a small piece in the back of the knee. And we'll see that here in a second. There we are, removing just one little small section in the back of the femur, and just smoothing off some of the rough edges, and then the actual pieces, can be put in there. They actually send some plastic pieces, which are trials, just to check the alignment. That's what they're doing here. Then there's a guide that fits on the tibia, allows the surgeon, again, it fits perfectly, it allows the surgeon to put some drill holes in there, a little slot where the keel of the implant fits. And now basically the knee is ready to put cement on and cement the tibia into place. The femoral piece is cemented on place, and then the plastic bearing is placed in there. Again, that's a trial bearing, and when you're happy with the trial bearing, and they usually send a couple of additional sizes if you need to adjust that, you can actually put the actual bearing snaps into position, and that's basically what a replacement for just one side of the knee would look like. And basically that's what the x-ray would look like afterwards, just basically the one bad area of the knee has been replaced. So you get the advantages of this system is it covers the femur, completely. It covers all the articular surface. It covers the entire, tibial surface. The actual piece will be fit on the tibia, will be right on the edge of where the tibia used to be. The front to back will exactly, match the tibia. And since this is all based on a computer model of the knee, the actual alignment of the knee and the forces across that knee will basically be the same as they were before the knee developed arthritis. Since it's patient specific, we haven't removed too much bone. We haven't damaged the ACL. The patient still has their own ligaments. We've done very limited bone cuts, and we've preserved most of the bone. The knee replacement, Conformis also has that I've mentioned before, they also have a total knee system. And basically the total knee comes with basically custom made guides that allow the surgeon to remove only the areas where the arthritis is in the knee, so that ultimately when the implant fits, it's going to be, aligned basically perfectly. This is some of the view that the surgeon gets to show him how the implant's going to fit on the actual patient's bone. These are patient-specific. This is actually an X-ray taken of the Conformis's total knee replacement. The biggest difference, if you looked at it, would be the distance from here to here, whereas in a normal knee, that might be almost 1.5 inches. Probably in the Conformis knee, it's more like 5/8 of an inch, because again, only the worn cartilage has been cut off. Very little bone was cut off here. So basically, we've preserved most of the bone. What's the potential complications of any surgery, any joint replacement? Infection, blood clots, medical complications. Usually, you have to operate on about 200 or 200 knee replacements to have one significant complication. It's about 0.4%. What's the complications that can come of the actual implant? And sometimes these don't occur initially like the surgical complications, but over a period of time, loosening or subsidence, where the metal pieces actually kind of sink into the bone because they don't have enough support. Polyethylene wear, where the plastic, the piece that fits into the knee, wears out, and persistent pain. What can you expect, after surgery, whether you had, a partial replacement, full replacement, out of the hospital within a couple of days, beginning your recovery, usually at home, usually able to walk on your knee soon after surgery, usually going home with a walker. Hopefully, probably by the 2-week mark, being utilizing just a cane. Long-term results depend upon the work in rehab. Knee rehabilitation is rehab dependent. You've got to work hard right from the very beginning to get the normal bend in your knee, or else patients will continue to have problems, down the road. So we start out early with aggressive therapy. By 6 weeks, most patients are able to get around to their normal activities, driving a car, shopping, typically if they're a golfer, they may be actually out there, putting or doing some chipping. And most of the time, by the 3-month mark, somebody's back to starting to play tennis again, racquetball, hiking, normal activities. This is a picture of a partial knee replacement. That's a close-up at the time of surgery. There's the x-rays afterwards. Again, just to recover some of the advantages of the resurfacing or ConforMIS type system. Minimal bone cuts, only replaces the worn areas, more natural because you still have your own ligaments. And if you ever had to, you could still have enough bone left that you could convert to a regular conventional knee replacement. I'm going to show you a picture of an actual surgery. If you want to get squeamish, you can turn away. Basically, where this speeds it up, starts with a basic exposure to the knee. Again, this is going to speed up to where we actually then are almost down to the actual bone. We cut through the capsule, get down to the bone. We remove some of the bone spurs with a pair of rongeurs, and this is actually the femur we're working on here. There's the jig in place. We're drawing a line that demarcates the normal cartilage from the implant. That guide was specially made for the patient. then we're taking that ringed curette and basically removing, all of the worn cartilage. Some patients basically have removed all the cartilage for themselves, so we just basically remove what's left. There's the guide that's been pinned into position. We've removed a small section of the proximal tibia. We then pin the femoral guide on, do our posterior femoral cut. Now we've basically made all of our cuts. We're going to clean things up in there, remove the meniscus, wash things out good. Put some additional drill holes in the femur for the cement fixation, and then also prepare the tibia. You'll see that in a close-up view here. Basically, this is what the knee looked like, before all the implants were put in. We're getting ready now to take the tibial guide and put that in. Make a few additional drill holes here, and then another slot for the keel. Again, we use the same types of drills you use in your basement, only medical quality. And here we are, we're actually putting the pieces into position to practice to make sure it all fits together. Here we are, we've prepared the cement that goes on like butter. It hardens up in about 10 minutes and becomes rock hard. And then we'll cement the tibial component on here. And we've put cement on the back of that also. And then that gets pressed in, and we remove the excess cement. We've put the actual piece of plastic, we put the femoral piece on, we remove all the extra cement, and we allow it to heal. Once it's healed, we wash it out and sew it up, and then the patient goes to the recovery room and starts their recovery. Before we go any further and ask questions, I'm going to introduce Tom Toothaker. He's one of our physical therapists. He'll talk a little bit about therapy, and then we'll both be available for any questions that you have.
I'm just going to use the microphone, so I'll just use that right there for me.
Do you just want to use that?
I don't know how to use it.
Just click it on.
Who's ready to get their knee replaced? My name is Tom Toothaker. I'm a physical therapist here at the Orthopaedic and Spine Center. The name is Toothaker. My dad is not a dentist. There's no dentist in my family. Everybody wants to know. PT. Anybody had PT before? All right. So, almost everybody here. So, it stands for physical therapist, right? Not pain and torture. Though the ones that have been there already may not agree with me. There is some discomfort that comes with it, but our intentions are good. So, what do we do? The biggest thing is education, okay? So when you come and see us, whether it be for just generalized knee pain or it was for your knee replacement, you want to know what's next. What do I do? So we can help you with posture alignment, body mechanics, lifting mechanics, talking to the microphone. We'll do this through exercise, so range of motion, flexibility, strength, stability, balance, manual therapy techniques, so hands-on techniques to help assist with range of motion, decrease pain, increase strength. Modalities, so you've got hot packs, cold packs, electrical stimulation, all else fails, we just shock it out of you. Just kidding, that's just something that usually feels pretty good, and ultrasound. So what to expect when you come and see us? You go and see Dr. Snyder. He says, I think you should do physical therapy. You come upstairs, you make an appointment with our lovely ladies, and you come into our room for the first time. You do an evaluation, okay? Usually lasts about an hour. Have loose clothing. If you're coming right from work, that's fine. We can work around it. Examination. So we're going to check your range of motion, your strength, your flexibility, balance, do some functional tests. And from there, we're going to come up with a personalized plan of care, okay, for you. We all have different goals. We have knee pain, but some people just want to get up and walk. Other people want to return back to sports. And then it's a gradual process. Remember this, guys, it doesn't happen overnight. So you've had pain a lot of times for weeks, months, years, okay? It's not gonna go away over 2 visits, okay? It takes time for your muscles to adapt, strength, flexibility, so on and so forth. Dr. Snyder talked a lot about non-operative and operative procedures. In general, when you come and see us, whether it's just knee pain or a knee replacement, there are some kind of basic goals that we're going to work to achieve. Decrease pain, right? And then increase range of motion and strength to improve your functional mobility and activity to daily or your tolerance to daily activities. So, like I said, everything from getting up out of a chair to walking to getting back to the sports that you liked to enjoy and play before. Some common non-operative diagnoses. Already went over: patellofemoral pain, muscle strains, ligament sprains, osteo and rheumatoid arthritis. Anybody have arthritis? Yeah? Okay. If anybody told you don't move, don't listen to them. Exercise, okay? Mild to moderate exercise, been shown to help. Leaps and bounds, okay? And that's what physical therapy can help you with. You'll hear this all the time: exercise, right? Well, what does that mean? What does it mean to exercise? Lose weight. How do I do it? Activity modification, right? So you're supposed to modify what you do. How do you do that? That's what your physical therapist will help you with. Non-operative, I just went over this. So symptoms, we're going to try to help you minimize or resolve them. And usually it's through self-managing your own symptoms by showing you what to do, okay, or what activities or exercises to perform. Operative procedures. Okay, so Dr. Snyder did a great job, did your surgery, now you come to us. Now it's time for rehab. So things like arthroscopic surgery, tendon repairs, ligament repairs, total uni and bi-compartmental knee replacements. So the biggest thing is we're your tour guide. Okay, well, that's how I see it. So when you come in there, you know, you're going to start from day one. If it's a knee replacement, you're learning how to transfer, you're learning how to walk again, you're learning how to get up out of bed, simple things. Education is going to be huge. You want to know, what can I do, what can't I do? And then usually it'll last anywhere from a few weeks to 3 to 4 months, depending on how invasive the surgery was. And so what do we expect from you? So I told you what you can expect from us. You guys have to be consistent, okay? You can't come to therapy just one time and be done, all right? 2 to 3 times a week, usually for 4 weeks, couple months, depending on what's going on. We're going to provide you with the tools. We're going to show you what to do, how to do it. You guys have to do the work. Now, if I could sit here and do squats for you, I would, if it would make you feel better, but it's not going to work. You guys have to do it. And then after that, you know, a lot of times we'll take you to a certain point, okay? We may not get you to be 100%, but we'll get you to a point where, okay, you now can take it from here, be independent with your program, and take it that rest of the way, okay? So this is a quote that I got from a gym that I used to work at and train at. And it was right up on the wall, and I'd see it all the time, and I'd say, oh, that's kind of fun. But it makes sense. You know, we don't stop exercising because we get old. We get old because we stop exercising, all right? Now, I know there's a lot more that plays in that, but basically it's take charge of your health care, okay? So, you know, you want to be in charge of what your body can and can't do, not the reverse. And any questions? Yes, sir.
What's your typical experience in terms of range of motion that you had before surgery, and even with good rehab, do you recover 100% of range of motion, 90%? What's sort of the average?
For a knee replacement? As in how much motion should you expect to gain in general? It's probably not going to get back to the other knee. There are certain limitations with these knees. Dr. Snyder might have a little bit better answer for that when it comes to typical ranges.
I guess let me repeat the question then. The question was how much motion will you get back after you've had a knee replacement?
From the original before you had it, let's say you had 100% before, even with good physical therapy, do you get 100% back, or is it typically 90 or 80% or?
Yeah. The biggest factor in how much motion you'll get back after a knee replacement is typically how much motion you had before the knee replacement. So if somebody had basically 100% of what their motion was, and usually when we talk about motion, we talk about a 0 being, your knee fully straight. Usually most patients can flex their knee to about 125 degrees. If you have that much motion beforehand, then you'll probably be able to get 125 degrees. But if you've gone through the last 20 years and your knee has been so stiff that you only had motion from 0 to 80 degrees, then you may not get 125 degrees. You'll probably get somewhere between 80 and 125 degrees. A question?
Yes, sir. Will you perform the knee replacement on both knees and whatnot?
The question was about performing knee replacements on both sides, and the answer is yes. There's a couple of factors that are considered. A lot of patients have basically, developed arthritis due to natural aging, genetics, for whatever reason. If you look at their x-rays, they have the same, basically identical x-rays on both knees. So it doesn't really make sense to subject them to one surgery, a long rehabilitation, and then turn around and have to go through that same process again, especially if they're, they have two bad knees, and after surgery, they still have one bad knee that then has to help them, support themselves during the recovery process. So the other factor, that comes into play is if you're healthy enough. If for some reason, you have a lot of underlying disease, whether it's heart disease, then there may be times when it's recommended that you do one knee at a time. But for the average patient, if they have two knees that need to be replaced, most of us feel, that you can go ahead and do them both at the same time with one operation, one recovery process. And, I think the other thing is you talk to a lot of patients that say if they had to go through it twice, they might not come back and have the second one done.
Also, have you ever had a custom knee replacement that didn't fit?
No, the question was, have we ever gotten a custom replacement that didn't fit? And the answer is no. And the reason for that is that after your CAT scan is done, it gets sent off and a model is created. At any process along that line, if the engineers that are developing the actual implants feel that the anatomy of the knee that they're designing implant is such that there may be a potential problem and it exceeds some of the design parameters, they will get back in contact with us and ask for clarification. So there's a very good checks and balances system on that. Question in the back?
Now, one of your charts showed that 20 to 40% of your total knee replacements could have been solved by partial replacements. Is that statistic a result of the patient demanding a total replacement or the surgeon making a misjudgment?
Yeah, the question was about that slide that showed that 20 to 40% of patients who had total knee replacements, probably could get by with partial knee replacements. And that's probably has to do with surgical training, the fact that some areas of the country, for whatever reason, partial replacements haven't caught on, and basically, everybody, no matter whether they have just a little bit of arthritis in one side of the knee or have arthritis in 2 areas or 3 areas, everybody gets the same treatment. And I think that worked well, 10 or 15 years ago, but nowadays with our newer technology, newer manufacturing techniques, we've all seen, what the amount of data that can be stored on an iPad or an iPhone. We're still doing, a lot of people are still doing knee replacements the same way they were 20, 25 years ago. and the technology has changed, and the custom implant is just a way to basically incorporate all that knowledge and all those manufacturing techniques which have been happening in a lot of other areas to medicine, specifically to orthopedics. Question?
Yes.
Yes.
I'm in the process of receiving the series of 3 injections. And tomorrow, I'm supposed to get the 3rd one. But listening to you, I want to know if there's any advantages of continuing that, or what would be the disadvantage of just letting it go and use WT-40?
Well, the question was that the patient has had 2 shots of the jelly type solution, and should they continue that? And again, if the shots are effective, then that's basically can be a treatment. And if shots are effective and a patient can still, do what they want to do, they can still get around, they can do all their normal activities, they can exercise and get by with injections, then I don't think anybody would say you've got to have your knee replaced. Basically, the time that you're going to get a knee replaced is you've done the injections, and maybe it eliminates some of the pain, but you still, you can't get up. You can't get up with your kids. You can't walk around. You can't pick up your grandkids. You can't, when the rest of the family goes off for a walk in a park, you're the one that's left behind. And if you can't do the things you want to do, then that's usually what drives you to go to that next step, to get a replacement.
My question was, should I get the 3rd one? Would it be a disadvantage? I've already had 2.
The question was, if you've had 2 shots, should you get the 3rd? And the answer would be yes. You want to finish out the series. If you're getting a type of injection that's designed to be 3 injections, you should get all 3 of them to maximize the benefit.
Question.
Okay, here, a question over there.
Simple question. Walking is considered or is recommended for the patients. If during walk it pains, does it really hurt the knee or it helps the knee?
The question was that walking is considered good exercise, but if walking hurts the knee, should you continue to walk?
Yes.
Well, I think walking is a great exercise. The only disadvantage that walking has is that with every step we take, we're putting our full body weight, across our knee joint. So that if walking hurts, then by definition, it's probably, producing inflammation, it's probably producing pain. And for that person, probably shouldn't walk for exercise, but should probably find other, activities such as riding a stationary bike, doing an elliptical trainer, or a swimming pool, or something that doesn't load the knee as much. And what I tell a lot of patients is that a lot of patients like to get up every morning and walk 2 miles, which is fine. But if that gets to the point where it's aggravating their knee, then maybe if they build in 2 days a week where they, instead of walking 2 miles, they ride a bike for 20 minutes, then they're doing some cross training. They might find that if they walk 5 days a week, or in other words, walk one day, ride a bike the next day, walk that day, ride a bike the next day, build in some low impact exercise, they may be able to continue that way for a number of years without ever having to have anything else done. In question.
My husband has knee problems and osteoarthritis, but my question is, we are very much afraid of surgery. So do you think that this seamless jelly type of injection first, one should try that, then if it doesn't work, then we should go for
The question would be, the question was, if your husband has osteoarthritis, afraid of surgery, should you have the Synvisc? I mean, even if somebody probably wasn't afraid of surgery, they should still probably should consider, all of the options that are out there. I mean, we don't like to ever start with surgery. We always want surgery to be the last choice. I mean, we want to go through things in a logical way. So, question?
Yes, doctor. About a year and a half ago, you did endoscopic and I had a torn meniscus, I guess it is. And now I've started using exercise and going to curves and doing Zumba, and I see that the pain is starting to come back. What am I doing that I shouldn't have been doing since then?
Well, again, the question was after a knee arthroscopy, somebody's able to be more active, and because of that increased activity, the knee starts hurting again. And the answer might be something as simple as a periodic injection into the knee to calm down inflammation. Or it might be not to do Zumba 3 days a week, but maybe 2 days a week, and that third day do water aerobics or a low impact exercise.
I noticed that sharp pain starting to come back afterwards, and I don't know what it is that's causing it.
Well, it's caused, what causes the sharp pain is the more force across the knee, the more activity, probably the more pain. So you want to build in some low impact, and again, possibly come to the office and have a shot put into the knee. So again, that's an easy treatment. Question over here.
Are you using these custom implants for all your knee surgeries, and if you are not, how do you determine when you
I give patients a choice. Some patients are in such a hurry to get their knees replaced that they don't want to wait for the 6 to 8 week period it takes to have the custom implant made. So for them, we'll use an off-the-shelf model. There are a few other cases that we didn't get into tonight that if somebody has such a pre-existing deformity to their knee, in other words, they have such an angled deformity to the knee, or they're missing an area of the bone of the knee because of a pre-existing injury, that they might not fit the criteria for the custom knee. So there are a few isolated cases where the custom knee might not be available to a patient. Somebody had a question here.
I already got a replacement in my right knee. And so I know it was a matter of time before I get my left knee done. We've already seen, Dr. Cross was my surgeon, we've already seen, the arthritis and the cartilage wear, and that like when I got this knee done, it told me I had to get it done. I couldn't pick it up and take a step. I blew my knee out. This one's not that bad. My concern is, how long do I wait? Like I watched my mother and my brother wait so long, they can't get on their knees and scrub the bathtub. I can't, because I didn't let myself suffer with that right knee. The left knee's been like popping and cracking for 3 or 4 years, but it doesn't hurt so bad. I feel like I need to get it done, but then I don't want to do more damage to it either.
So the question is, how do you know when you need your knee replacement? How long? And I think that's kind of an individual decision.
I'm in physical therapy right now with Mr. Toothaker. I was in a car accident, so I re-injured this knee as well. So we've been doing PT on it to get that stronger. The stronger this one gets, the more this one hurts. Like I feel like I'm wearing the cartilage down more while I'm in physical therapy for this one.
Yeah, I guess my advice to a patient when they're trying to determine when's the right time to get a knee replacement would really come down to some simple things. Number one is, are you purposely limiting your activities to try to favor a knee that's injured? Do you find yourself sitting in a chair, when everybody else is up mingling, talking? You find yourself saying, well, I don't want to go for a walk when everybody else is going for a walk? Basically, are you taking a seat and watching the rest of the world go by, waiting to get your knee done? In my opinion, if you're doing that, then you're probably, falsely lulling yourself into waiting too long. I think when you talk to a lot of patients that have had a knee replacement, they'll tell you that they wish they hadn't waited as long as they waited.
Right.
Now, so in the big scheme of things, you know, do you really gain anything by waiting a year, you know, for something that properly cared for may last 18 or 20 years? And subsequently, do you do more harm to yourself, you know, in waiting? What I didn't mention tonight was there was a very interesting article in the New York Times about 2 weeks ago. You know, we empirically, you know, say that, you know, if you put a knee replacement in somebody, they're going to be healthier, they're going to be more active, they can be healthier, maybe they're going to live longer. Well, they actually did a study, and they came to those same conclusions. They took a group of patients that had knee replacements. They took an identical group of patients who didn't have those knee replacements, and they tracked them out over a number of years and tried to make both groups equal, except for the fact that one group had knee replacements and one didn't. The group that had the knee replacements lived longer. You know, so again, it makes intuitive sense. The more active you can be, you're going to keep your blood pressure under control. You're going to keep your breathing under control. The more active you're going to be, you keep your diabetes under better control. So, as this article said, yes, you know, a knee replacement can save your life.